Hello, and welcome to Dialogues in Obesity, where visionaries meet to lead the change. I'm Rachel Deere. This program is supported by a grant from Boehringer Ingelheim Pharmaceuticals Incorporated. The grant is for scientific and educational purposes only and will not promote Boehringer Ingelheim Pharmaceuticals products directly or indirectly. Our learning objectives are: understand obesity as a chronic, relapsing, and treatable disease, gain practical strategies for screening, diagnosis, and treatment initiation in primary care, and address bias and stigma in patient interactions. And now, I'll turn it over to our host, Karli Burridge, a board-certified PA and is a Master Fellow of the Obesity Medicine Association. Karli is the co-founder and past president of PAs in Obesity Medicine, and also serves on the board of the Obesity Medicine Association and the Illinois Obesity Society. She is the founder and CEO of Gaining Health and is the Director of Clinical Education at Healthy for Life in Naperville, Illinois. Karli, take it away.
Thanks, Rachel. Hello, everyone. I'm Karli Burridge, and I will be your host for today's podcast. And I'd like to welcome you to Dialogues in Obesity, a podcast for primary care providers. This is part one of a two-part series designed to deepen primary care providers' understanding of obesity as a complex chronic disease. So join us as we highlight evidence-based approaches, practical tools for patient management, and real-world insights from leading experts in obesity management. I'm delighted to introduce our guest for today's episode, Dr. Michael Albert. Dr. Albert is a board-certified internal medicine physician and diplomate of the American Board of Obesity Medicine, dedicated to expanding access to evidence-based obesity care. He trained at Cedars-Sinai Medical Center in Los Angeles, where he served as a Kennemer Fellow and faculty member, and founded the Medical Weight Management Program at the Weight Loss Center. He is currently a clinical assistant professor of medicine at the University of Oklahoma Health Sciences Center and the co-founder and chief medical officer of Accomplish Health, a nationwide telehealth practice delivering comprehensive obesity medicine and medical bariatrics. Dr. Albert focuses on translating science into practical, patient-centered care and fostering a more informed, compassionate conversation around obesity. Dr. Albert, thank you so much for being here with us today.
Yeah, thanks for having me. Really excited for the conversation today.
Absolutely, me too. And I'd like to start by asking you to kind of explain to our listeners why this series is so important, what it's about, and why we're starting with the topic of obesity as a chronic disease.
Yeah, I think it's one of the most important topics when we discuss obesity. And I think a lot of it has to do with the fact that we've inherited stories about obesity that aren't rooted in biology and that are frankly scientifically incoherent. Understanding obesity as a chronic disease isn't about kindness, although I always think that's an important consideration. It's just about accuracy. And the problem is when we frame obesity as something like a willpower narrative, the issues that come from that create stigma, they create bias in the way that we think and relate to people and their struggle. And ultimately, what this results in is real-world harm for people living with the disease of obesity. Stigma creates misunderstanding, it blocks treatment, and ultimately, when we reframe it in a more scientifically coherent way, understanding that it's rooted in biology, it creates better understanding and ultimately opens the door to care.
In your mind, how do most clinicians think about and understand obesity, and what are the limitations of those views?
Yeah, I think it's super important that we address, some of the current framing around obesity or weight as in general. I think historically we associate it with this very conscious experience, right? That we understand that the way that people navigate their day, the way they think and relate to the world can be boiled down to simple things like choices or simple manners of discipline. And it's actually far more complicated than that. And that wasn't something that I even knew going through my medical training. What are the different aspects of that? So obesity is more complicated than a simple choice. And understanding the biological framing and underpinning of how weight is regulated in the body allows you to better understand the disease of obesity, the struggle of your patients, and ultimately to provide better care. This is a really important thing. It's not a story about willpower. It's one grounded in biology. And there's really, really strong evidence that we've learned over now decades that help to inform that understanding. For example, we've studied animal models where they've manipulated the way that neurons function in the brain by either knocking them out, by either stimulating them. And what we've been able to show is as easy as turning off a switch and on a switch, we can completely change the behavior of that animal. We can completely change the way that weight is regulated with simple manipulation of the underlying biology. Extending that further, we have studies that show when we decorticate animals, so when we detach the brain function from the higher functioning centers, the sort of parts of the brain that we often associate with the conscious experience, with the engaged everyday life and the higher executive functioning, that animals continue to go on and feed and eat and maintain their weight at near baseline levels. A lot of this has then been translated to other, even human models. There was a story that came out in the media recently of an individual in their 20s that had a rare condition called hydranencephaly. And this is a condition where humans are born without cerebral hemispheres. So they're not born with part of the brain that we often attribute to being truly human and unique. And despite that, this individual was able to eat and feed and maintain their weight, and they're alive well into their 20s. We have many number of examples of these kind of rare, different developmental or acquired, abnormalities of the nervous system that impact weight in a number of ways that go far beyond the conscious experience. I think the last bit of evidence that really drills this point of the biology is what we've seen with the development of treatments and what they've told us and informed us about biology. There's no better example of this than a lot of the new drug development that has come out. And what we've shown is that when we manipulate peptides and small, tiny chemical messengers that go in and modify nervous system signals, that modify brain responses and hormone pathways, that we can almost instantly or over a period of time change the way that that body regulates weight on a fundamental level. And this is not a matter of willpower. These people aren't choosing to do things fundamentally different in many ways. It is the way that we are re-regulating their system, often a system gone wrong, that allows them to more sustainably manage their weight. And these drug trials have really underscored the significance of how biology is at the root of one's ability to manage their weight. The analogy I often give is telling someone to just eat less to manage their weight is like telling someone to just stop breathing. Breathing, as well as eating, is regulated in parts of the brain that are part of rudimentary structures in the hypothalamus and even in the brainstem. And yeah, someone might be able to stop breathing or hold their breath for a short period of time, but we all intuitively understand that our breathing and our ability to regulate how quickly and the way we breathe is happening in the background almost automatically without much of even any thought at all. And similar to that is the way that weight works. So the way that it's been framed historically, even among healthcare providers, is really not scientifically accurate. And that is mostly to do with the fact that people don't appreciate the biological nature and the way that weight is regulated.
Absolutely. And I love that example of breathing. And it's actually an example that I use with patients all the time because it makes a lot of sense to them, just as it does to us, that yes, we have some conscious control over our breathing, but ultimately, right, it's biologically regulated. And just because we can temporarily control it doesn't mean that our breathing is based on willpower, nor is our appetite regulated by willpower, right? This is a biologic condition. So thank you so much. That were some great examples. So let's switch gears a little bit and talk about some of the population level data. So what does that show about the prevalence of obesity and also its impact on health?
Yeah, I was fortunate to be involved in a number of recent studies that look at population health data. My research group out of Johns Hopkins, led by Jackie Yao, looked at a new database supported by the NIH called the All of Us Research Program. And basically what we looked at was a sample of over 200,000 Americans. These are people that have all sorts of ailments and are supposed to be representative of our sort of population at large. And what we showed is that obesity actually very predictably saw a sort of progressive phenotypic appearance in health. And what I mean by that is with increasing indices around weight and body size, and in the data we looked at, it was specific to BMI, because that's how sort of weight is often framed in a health perspective at a population level. With increasing BMI indices, we saw an increasing and sort of stepwise increase in risk for a range of other health issues. The most notable that we saw and the strongest correlation were things like obstructive sleep apnea, metabolic associated steatotic liver disease, type 2 diabetes. These had the strongest correlations. And those correlations, once again, were sort of lockstep with increasing BMI, demonstrating this sort of phenotypic progression or dose-dependent response. And so what we know is with more progressive forms of disease come more progressive forms of risk. The other sort of study we did was looking at the daily impact. It's not enough to just say, okay, I know that weight impacts your risk of acquiring other diseases or other complications. We wanted to understand how it impacted people's everyday lived experience. And what we saw is very similar to that increasing risk for other related comorbidities, an increasing risk in the way that it impacts people's daily function. We saw decreases in energy, decreases in physical functioning and self-reported quality of life and health. And that correlated once again with progressive increases in weight. Interesting enough, often people with even just modest weight gain, where there may not be as apparent disease risk, did also report decreases in their quality of life and physical function, even with just mild or modest increases in weight, or what we would often sort of characterize as low risk or slightly overweight, depending upon the clinical scenario. And so I think the point is what we showed in a nationally represented sample is that obesity has real consequence in terms of the way that the body functions, not only in terms of disease risk, but also in the way that people live and how they can function and engage in life. And if that is not a representation of what a disease process is doing, I don't know what else is.
Absolutely. You're so right. And I think looking at things like quality of life and function and pain levels and all of those other things is really important as well, because sometimes people like to talk about the cardiometabolic impacts of obesity. And yes, we know that there are many of those, but we also need to consider all of the other complications of obesity besides the cardiometabolic. Even those are so important. You know, the functional limitations, quality of life, those are so important. So thank you so much for highlighting that. So what do you think are some of the factors that make people more vulnerable to weight gain in today's environment?
Do we have enough time? No, I think there's a lot. Here's the irony. Over 100 years ago, we had all of these really ambitious people who, had a vision for making a better world for humans. This is a world that scaled to meet the needs of a growing population. This is a world where technology could enhance the quality of life. I think, unfortunately, we as organisms, as humans, did not evolve in that world. That was a world that was thrust upon us, really, that our biology wasn't really ready to accommodate. And so I think what we've seen is this clashing of genetic potential, wherein our bodies evolved to be very effective at storing energy, at combating things like famine, and really utilizing every little resource and morsel that we have at our disposal. And what we didn't account for and didn't really evolve to manage are the benefits of what I would call modernity, which is the convenience of modernity, the excess resource that modernity has brought, which has come with a lot of tremendous benefits. But I think some of the unintended consequences of this sort of industrialized living and modernity have been things like shifting the population's weight, and with it, the health consequences that go hand in hand. And so I think when we look at what are the things that put people at risk, a lot of these are things that we appreciate as part of modern living. And I think that also frames the challenge that we have. If we are going to effectively manage weight at a population level, there's not going to be a single intervention that is going to be sufficient to make a meaningful dent in reversing the course that we have seen over the last 50 or 60 years. It's going to require us to look at our priors and say, is this the right way to live? Do we need to reconsider the way we construct society, the way we build culture, and all of these things? These are tough questions to answer, especially as we've all adopted to the way of living in modern times.
Absolutely. Yeah, those are some real challenges. And as you mentioned, there's so many things that are affected by this that we could spend a whole week talking about all the different factors. And of course, the factors are different for different people, right? Depending on their genetics and things like that. So, that's kind of what can contribute to the development of obesity. But let's talk a little bit about why weight reduction and keeping that weight off long term is so challenging from a physiologic standpoint. Can you explain that a little bit?
Yeah, I think this is the part that I think really frustrates people when you talk about them. Many people, particularly when I see in clinic, have gone through dozens, if not hundreds of attempts to lose weight over time. It's not for a lack of effort, I can tell you that. But what they found is sustaining any meaningful weight reduction is incredibly, incredibly difficult. And we know one of the most difficult reasons, which I think there's a little bit of debate over whether this is a normal physiologic response or part of the disease manifestation, but something we have a lot of confidence occurs in a majority of people, is the adaptive response that the body goes through when someone is undergoing any type of weight reduction. When someone's undergoing weight reduction, the body senses the changes that are happening within the body, and it presents these sort of counter-regulatory effects. And part of this regulation that is taking place, we believe, is a part of the genetic survival response that we have acquired as humans over time that allow us to survive periods with low energy, with famines, etc. But what we see and what we've been able to measure is that as people are undergoing weight loss, they see spikes in hunger and dysregulation of appetite. They see reductions in things like satiety or measures of satisfaction with eating similar amounts of food. They see metabolic adaptations wherein their body actually becomes even more efficient. And that results in reductions in things like metabolism and energy expenditure. And the collective change, the collective hormonal and neurologic response ultimately leads to weight loss slowing, and for many people, weight recurrence over time. And so what people often experience going through any type of weight loss or weight management endeavor is this sort of yo-yoing of their weight over time. But often when you look at the overall trend over time, it's one that looks very progressive, owing to the progressive nature of disease and weight in general. And so I think this sort of biological resistance to sustained weight reduction underlies a lot of the frustration of lived experiences of people with weight health problems or obesity.
Absolutely. And this is why it's so important that we talk about this as a chronic disease, right? Recognizing that it's not just the initial weight reduction and then people have lost the weight and they're great, right? and explaining both to patients and clinicians why keeping that weight off is so challenging. So you described it in a great way, understanding the physiology behind that. And so that people, one, can stop blaming themselves, and two, understand the need for a long-term plan. So thank you so much for explaining that so well. So I think a lot of primary care providers are starting to understand the importance of addressing obesity, but a lot of them are not sure how to bring up the conversation with their patients. And sometimes they may be afraid to offend the patient by bringing up the topic of obesity or weight. So what are some ways that clinicians can talk about obesity to their patients that are accurate, clear, and also respectful?
Yeah, I think this is super important because for people to get better, they have to feel like the ability to ask for help is accessible, and they're not going to be shamed and judged for even broaching these concepts. So it is, the onus is on us as healthcare workers, as frontline workers, to create an environment that feels accessible for people to seek care, because historically it hasn't been. If we're going to be candid, there's been a lot of judgment and shame. So how do we begin to reframe that? Well, one, as we talked about today, this is not a matter of willpower. This is not a personal or moral failing as to why someone struggles to manage their weight. We just have talked at a really high level, but even on a basic level, there's a lot of complex environmental factors that make it particularly difficult to manage weight, full stop. And that's without even considering any of the unique biological features of the disease of obesity. But I think the other part of it is framing obesity once again as a chronic disease. We understand it from studying that it is a chronic, progressive, and relapsing disease. And that disease not only means that there is a biological basis to it, right? There's a change in the form and function of the body, but it also means that there are real consequences to it, that it can cause harm. And as I shared today through some of my own research, that it impacts the everyday living of people. So understanding that and making sure that it's framed in a way where this isn't about blame, and validating one's experience helps to reduce the shame of living with obesity or weight problems. And ultimately, it makes, once again, being able to have conversations more accessible. It improves understanding between provider and patient, and it creates a positive working environment around what is hopefully a mutual effort to help that person manage their weight more effectively. And if you do that, that lays the foundation for conversations around providing evidence-based effective treatments. Because then at that point, someone is willing to receive the type of help because you validated their lived experiences and you haven't blamed them. And I always say, if nothing else, there's no benefit in blaming people. The data on that's very clear. It only results in harm. It only causes people to avoid seeking help. So why do it? Like, put the moral thing aside. There's no benefit. It doesn't help people to shame them. So if we can move away from this shaming narrative, this sort of bias and the stigma and the way that we've historically framed it, to one that is more compassionate, more rooted in coherent science and understanding, then I think we're going a long way in beginning to change the dialogue around obesity.
Absolutely. And I think one of the important things that you mentioned obesity is chronic, progressive, often relapsing, but you also mentioned it is treatable, which I think is a very important component of it as well. So what are some tangible, practical steps that primary care providers can take when assessing and treating obesity in routine care?
Yeah, I think one is first to address it. And that sounds very simple or overly simplistic, but you'd be surprised at how many primary care providers in general are not addressing weight with their patients. So that's one, is first recognizing that it's something worthy of addressing. And then two, it's understanding how to address it in a way that's going to be well received for patients. So we often talk about asking people if it's okay to talk about this. Is this a time and place to be able to address that? just leaving that door open allows a patient to walk through on their own terms. You have to understand, this is not the first time that a patient living with obesity has thought about their weight. And it's actually insulting to them if you act like they're not aware of many of the health problems that they already deal with. But the other side of that is it's not always appropriate, and not in every forum should you be talking about weight. If someone's coming in with a runny nose and they have issues and they would need help addressing their common cold or whatever, it may not be the right time to talk about their weight. And so asking if this is an appropriate time or forum creates the opportunity to have a more productive conversation. And then I think beyond that, it's understanding, as we shared here, if we can create a structure around assessment, which begins at one, identifying people at risk. And while I think there is a change in the way that we're thinking about qualifying risk and who has obesity, it's always an easy place to start because it's been validated, looking at BMI as an initial screener. All right. And then using a lot of what we understand around obesity-related risk factors, things like, is the weight impacting someone's physical functioning? Do we believe the weight is impacting their mental and emotional well-being, their cardiometabolic health, to help you further stratify maybe how impactful is this excess weight having on this individual's life, is a really useful way to not only identify who might be at risk and then understand how severe that disease may be. And if you can do that, you can begin to understand what kind of treatments might be appropriate. And the reason I say that is for people who are at higher risk, like we know with higher classifications of obesity, people that have more comorbidities or impairments of their physical functioning, mental health, or cardiometabolic physiology, we know they're going to be at even higher risk. And those are the people that are going to benefit the most from more aggressive early interventions. Things like some of the latest medical treatments, things like procedural and surgical excellence. These are people for whom the science tells us that sort of more modest interventions like structured nutrition or behavioral support are likely going to be insufficient in helping them to really reduce their risk and get on top of their weight health issues.
Absolutely. And what do you think about waist circumference? Is that something that you think primary care providers should be taking on their patients? Or do you think looking at BMI and looking at weight-related complications is sufficient? What are your thoughts on that?
I think the data is pretty clear that if we have anthropometric measures that approximate visceral adipose tissue or central obesity, of which weight circumference is one, waist to height or waist to hip ratio are another, those are great additional measures to better understand one's risk and how severe their disease is. I just am very sensitive to the fact that measuring waist circumference reliably is a challenge. And so the practical translation and my concern is that may not be implemented consistently the right way. That does not mean it shouldn't be considered if you have a way to do it, which requires you to have the materials to do it and the training of the staff to do those things. But at a minimum, we should be using time-tested screening tools like BMI and be asking appropriate histories that begin to understand the risks and the lived experiences to better understand how severe is the disease and how someone's health is being impacted. That can go a long way with telling you information about how significant this is for that individual and how serious we need to be taking it and what kind of things we need to be considering in terms of intervention. So I think waist circumference absolutely is an additional tool that we can use to better understand severity and grade, the disease. But I don't want people to let that be a barrier for beginning to have a conversation.
Okay, awesome. We talked about a lot of really important things today, and thank you so much for all your amazing insights. So what are some of the key messages and takeaways that you want listeners to take away from this discussion?
Yeah, I mean, obesity as a chronic disease and moving away from this willpower story and narrative to one that is scientifically coherent, that understands the biological nature of weight regulation, that begins to hopefully undo a lot of the stigma because of our improved understanding of how weight is regulated. And that the idea is that this impacts people in a number of different ways that we only begin to appreciate because we're open to understanding and we're open to asking. And that even though for many patients, it may be really hard to manage your weight, and there may be some things because of the biological nature of disease that even are outside of your immediate control, that we ever increasing have a number of treatments. And so I always say to my patients, your responsibility isn't being able to affect every aspect of your biology. That's unrealistic. Your responsibility as a patient is to be open to the wide range and the ever increasing number of effective evidence-based treatments that we have. That is your responsibility as a patient. And so my job is to work with you to figure out how we can get that done and how we can support your journey to the extent that that's something that you want to do as it relates to your health. So I think understanding the disease of obesity, that this is not a personal failing or matter of willpower, and that there are treatments available that we can begin to support our patients in receiving treatments that they frankly deserve, I think goes a long way into making a difference, at the end of the day.
Perfect. Well, thank you so much. Thank you for your time and your wonderful insights. And lastly, where should listeners go next if they want to learn more or stay engaged in the series?
Please go to the Obesity Society, Dialogues in Obesity, and make sure you listen to where you can get down and download all podcasts.
Thank you so much. Rachel, back to you.
Thank you, Karli and Dr. Albert, for a wonderful and insightful conversation. And thank you all for watching. We'll see you next time.